Still morning, right? Good morning, everyone. It's good to see old friends. Thank you for the opportunity to. I was asked to talk about new EVAR graft designs and what does the future hold. And I thought about this, and I thought it would be best for us to have a better understanding of what the new elevated bar for EVAR outcomes are, for us to understand what the future technology needs to have available to it. So these are my disclosures. So traditionally speaking, right, EVAR has aimed to provide a less invasive and hopefully durable alternative to open aortic surgery. And if we look at some of the traditional means by which we've gauged EVAR outcomes, these have included things such as freedom from aneurysm-related mortality, freedom from rupture, secondary procedures, and freedom from sac expansion. But nowhere in this paradigm are we talking about dynamics or remodeling of the aorta like we do with dissections. We just heard of that talk. And nowhere in this are we talking about regression or remodeling of the aneurysm. That has not been a factor that we've looked at. Furthermore, right, we just heard Dr. Banazadeh talk about the timeframes, right? We've looked at various trials, and one of the criticisms of EVAR has been, well, we don't have long-term data, and in the long term, it doesn't really bode as well as open aortic surgery. So we really need, right, everyone's demanding 5 and 10-year data, and 1 or 2 year data post-EVAR implantation has been dismissed as preliminary and essentially just feasibility or short-term safety studies. Well, and EVAR1 showed us this, right? EVAR1 with earlier generation experience demonstrated to us EVAR durability with comparable survival, but this came at a cost. It came at a cost of greater re-intervention versus open surgery. And so again, that's why some of the recommendations and guidelines remain a little bit questionable, right? But recently there's been a very strong interest in sac dynamics, and so it leads us to kind of say, wait a minute, we shouldn't really be high-fiving each other when we have Mr. Jones's 5.6 centimeter aneurysm that we put a Gore or Cook or whatever you have in there, and it's rock solid stable, and seemingly we're not seeing anything, and the aneurysm really is just stable. So the era of just hoping to put some sort of an equipment, whatever that may be, into the aneurysm and hope that it clots off, I think that era is over, because it's been demonstrated that not only sac expansion, but any failure of the sac to regress is associated with higher long-term mortality, and that's independent of reinterventions or endoleaks. Furthermore, aside from the survival benefit, and it's important to remember, and maybe we can talk about this in the question and answer section, is that it's not aneurysm-related mortality that's improved, it's all-cause mortality when we have sac regression. In addition to the survival benefit, we're seeing significantly lower odds of rupture and lower hazard of secondary interventions and complications. In other words, when you have an aneurysm sac that's regressing, that nidus for badness is eliminated. So instead of worrying and scratching your head about, type 2 endoleak, is it a type 1 or is it a type 3 or is it a type 4 or 5, endotension, all that stuff that we've been talking about for decades, those things really get eliminated when the aorta remodels favorably. And when I talk about sac regression, while the radiographic definition of it is that you need to have a 5 millimeter sac reduction, it is really major sac regression defined as at least 10 millimeter reduction in a 12-month period. That's what we're talking about here. As you can see in the picture down below, you can see a 1-year follow-up scan down on the bottom on the axials, and you see essentially complete collapse of that aneurysm onto that endograft. It looks very similar to if you were to take a cross-section of an open repair where we imbricate the walls of the aorta around the graft that we've sewn. I find it very hard to believe that aneurysm is going to re-expand with a couple of type 2 endoleaks back to that original size. And I think that while we don't have long-term data, but I think it's something that is just intuitively makes sense. And this is irrespective of the thrombotic burden, which tells you that this aneurysm milieu, even though it's quote-unquote thrombosed, it's a very much alive and biologically active entity. Here's a nearly 6 centimeter aneurysm. When you see the same cross-sectional area 12 months later, both on the coronals and axials, you can see that there is no longer an aneurysm. That aneurysm has completely and favorably remodeled around that endograft, and the thrombotic burden has not been a physical barrier to that reduction, which tells you that there's some sort of a reversal process, if you will, of some of those enzymatic processes and molecular pathways that were involved in that, granted that you're able to provide a favorable seal and to be able to get the proper exclusion, if you will, endovascularly of that aneurysm. So this, in my opinion, is the new elevated bar of EVAR. I think we've evolved as a community to understand that we've sort of moved away from hoping this thing clots off, and we've gone to a period where we need to talk about remodeling of the aorta. How can we get to 100% remodeling? And so that kind of gets into question about, not every endograft and every graft design or idea is created equal, right? We won't go into detail. We can talk about that later. So if you remember earlier, we talked a little bit about, well, show me 5-year data, 10-year data, 15-year data. That's important. But it turns out that that initial 12 months after implantation is a critical time period, because that 12 months, what happens to that aneurysm at 12 months can be predictive of your 5 and 10-year survival, right? In other words, I don't think it's a far-fetched notion to suggest that the fate of that aneurysm is sealed within the first 12 months of implantation. If you have favorable aortic remodeling and near complete collapse of that aneurysm sac at 12 months, the odds of you having a good outcome is significantly improved from a survival standpoint compared to a scenario where you have a rock-solid stable sac, and we used to high-five each other for something like that. I don't think that necessarily is the case anymore, right? And again, this is a rapidly expanding aneurysm. When I talk about that 12-month period, what we see is that the process, if it's going to happen, right? If it's going to happen, it's going to happen immediately. You don't have a rock-solid aneurysm, 5.5 centimeters, and it's been stable for 2 years. Now you have a type 2 endoleak, and you embolize a couple of type 2 endoleaks, and all of a sudden it decides to regress and remodel really aggressively on you. I have never seen that. There are more experienced folks in the room. If you've seen it, by all means, tell me. But I think if it's going to happen more extensively, it's going to happen immediately. So this was a rapidly expanding aneurysm. We treated it at 52 millimeters. You could see at 6 months in the middle, very pronounced remodeling, but that process continues, right? It continues to that 12 months, and you really should have a plateau at that point. I really don't think a couple of lumbars or an IMA are going to re-expand that aneurysm back to its original size. And so when we look again, what was shared recently at Charing Cross in the UK, that these stable sacs are not so benign afterwards. When you look at the Medtronic's Engage registry, for example, about 50% had stable sacs. They had 24% risk of expansion when you followed these patients out to 8 years, as opposed to those who had sac regression within that first year. Those only had 5% risk of sac expansion, and 84% of them went on to have continued sac regression down to about 8 years. So the point is that these stable sacs that we used to be very happy about, they're not so benign after all. It's like a tumor that maybe it's in remission, but it's going to resurface its ugly head at any point. Now you're talking about all these things because it's an active entity. Now these type 2s are going to come in 3s and 1s and what have you. And the same registry, again, showed us that in terms of freedom from all-cause mortality, freedom from endoleak, and freedom from secondary procedures, time and time again, sac regression fares significantly better than sac stability, and obviously better than sac expansion. And so some of the topics that are coming up nowadays, when we understand that this is the new bar, now we can start talking about endograft design. And some of the important topics that are coming into the picture is the concept of active suprarenal and infrarenal fixation. And that can have a variety of different configurations. I'm not here to sell one particular device or promote any specific device, but I'm trying to sort of point our thought into that direction. And so either the active fixation can be something that is an inherent feature of the platform, such as what you see with the Trio stent graft system, or it could be something that is used when we talk about, for example, use of endo anchors. And we know that there's about at least a 50% increased rate of sac regression when this concept is taking place, particularly in more angulated anatomy, such as the one you see here. For those of you who are interested, there's an interesting discussion that myself and some of the colleagues here had in Endovascular Today on this topic, so I'd encourage you to read it. And we had a resident corner that I sort of encouraged that Medtronic implement into that. So for the trainees, I think it's Julia Chen, my previous resident, has provided some really good insights into this topic. And then the other thing that's sort of coming into the picture is that the concept of customization is an important topic for discussion. Utilizing more lumen of the aorta within the aneurysm sac to be taken up by the endograft, and then displacing the flow divider as far away from the proximal seal as possible, which has been demonstrated to reduce the caudal forces antegrade on the endograft. And so that's another relatively interesting, from an engineering standpoint, an area that's being looked at as a potential contributing mechanism. And so again, all these talks about type 2 endo leaks and, is it coming from the IMA? Let me go embolize this. A type 2 endo leak the issue is these are more likely than not scenarios where you have not had positive sac regression and the nidus for badness has persisted, and there are occult types 1 and 3 that we're not detecting on current imaging. We heard a little bit about imaging earlier. Our imaging has not been stable enough or specific enough to be able to detect some of these things. So it could very well be that these type 2 endoleaks are merely outflow channels for occult types 1 and 3 endoleaks that we're not sophisticated enough to detect. And so I will summarize by saying that, in my opinion, I think sac regression represents an elevated therapeutic standard for EVAR, which I think should be standing for endovascular aortic remodeling. This process, if it's going to happen, happens immediately. It's progressive through 6 months. At 12 to 18 months, we should be seeing a plateauing of that process. And I firmly believe that the fate of the EVAR is determined within that first 12 months. So while long-term data are great, but I think critically as important is that 12 months after implantation. Obviously, design and adjunctive techniques come into the picture. And there's tons of areas for collaboration and research and investigation into how can we get 100% of these patients to that complete aortic remodeling phase. So thank you for the opportunity again, and happy to take any questions.